Shall we start? Good evening, ladies and gentlemen, friends. Thank you very much for your joining APOA Hand and Upper Limb Society special webinar. I am Professor Jeon, President-elect of APOA Hand and Upper Limb Society. Other than our regular webinar of APOA Hand and Upper Limb, we have a very special masterclass webinar in which we have TFCC, all you need to know today. We are very lucky and pleased to have 4 special speakers today. And at the end of this webinar, you can have a comprehensive understanding of this special disorder of wrist. Without further delay, I would like to introduce 2 renowned wrist and hand surgeons of APOA, Dr. Margaret Fok and Esther Chow, who is going to lead today's special webinar. Margaret, over to you.
Thank you, Inho. So good morning, good evening, or good afternoon to everyone, and depending on where you are. So our first speaker is Professor Toshi Nakamura. He's a professor for the Department of Orthopaedic Surgery, School of Medicine, International University of Health and Welfare in Tokyo, Japan. He graduated in Tokyo University and subsequently did a PhD degree there as well. He was a research fellow in Mayo Clinic as well as the State University of New York at Buffalo. I think a lot of people have known him for his treatment and classification of TFCC injury. He's the current editor of the Journal of Wrist Surgery, as well as he was the past president of the Asia Pacific Wrist Association. Today, he is going to talk about the anatomy, diagnosis, and classification of TFCC injury. Toshi, please.
I think that Esther, you have my video.
Yes, we'll show the video.
Good afternoon. My name is Toshi Nakamura. I would like to talk about anatomy, diagnosis, and classification of the triangular fibrocartilage complex. Triangular fibrocartilage complex was reported by Andy Palmer in 1981. He actually mentioned that the function of this structure is a stabilizer of the ulnocarpal joint, stabilizer of the DLUJ, a load distributor between ulna and ulnar carpus, and it allows smooth wrist motion for arm rotation. Now, the TFCC is recognized as an important structure in the deep ulnar side of the wrist. In 1996, I did a functional anatomical study of the TFCC. The distal surface of the TFCC shows a hammock-like structure, which can support and surround ulnar carpus, lunate and trochanter. Ulnar side of the TFCC is an ECU sheath floor and 6U portal. ECU sheath floor is the strongest part of the ulnar side of the TFCC. Then proximal side, you can see a radial ulnar ligament from the fovea to the distal surface of the sigmoid notch of the radius. This is the primary stabilizer of the DLUJ. Histological findings shows that the radial ulnar ligament arose nearly vertical from the foveal region to the base area of the ulnar styloid. As the rotation axis passing through fovea, so radial ulnar ligament easy twisting structure during rotation, while triangular fibrocartilage face to the lunate and trochanter. Then these 3 structures can rotating over the ulnar head during the pronospination. That is why the triangular fibrocartilage shows the hard hearing-like structure. Higher magnification of the histology shows that there is a sharpy fibers at the fovea. This suggests that the radial ligament is a ligament. Then tip of the ulnar styloid, you can see a hearing-like cartilage here. Then the connection of the TFCC to this area is rather weaker. So when you see an avulsion fracture or a fracture of the tip of the ulnar styloid, that is not the avulsion fracture. That is maybe the fracture due to impaction of the tip of the ulnar styloid to the triquetrum. The radial side of the TFCC shows the transition from the hearing-like structure of the radial cartilage to the triangular fibrocartilage, increasing the fibers, decreasing the cartilage cell matrix. Then very dorsal side and palmar side, you can see again sharpy fibers. So this area is a ligament. So three-dimensional structure of the TFC shows a hammock-like structure. Then radial ligament has a vertical insertion to the foveal region, which can easily twist during rotation. Diagnosis of the TFCC tear is a stress maneuver, which includes an ulnocarpal stress test for standard deviation with an supination or pronation. Then ballotment test checking the DRUJ instability. Then image diagnosis was mostly used MRI or arthrogram, then arthroscopy. This patient showed a severe DRUJ instability with an ballotment test. So there's no endpoint with this structure. Then right slide shows a moderate DRUJ instability. At least one dorsal endpoint in this patient. MRI showed a more precise structure of the TFCC. You can see a horizontal type tear or proximal slit tear or foveal avulsion on the coronal plane of the MRI. Arthrogram still are used, then it is quite useful to diagnose a more small tear inside the wrist, with such as an SL ligament tear, but also that it can demonstrate foveal avulsion in the right side or proximal slit tear. Then this patient shows that the dye goes from the ulnar head, foveal region, tip of the ulnar styloid, and ulnar side of the ulnar styloid. That means that the TFCC was completely detached from the foveal region and the ulnar styloid region. Arthroscopy is a gold standard diagnostic tool for TFCC injuries. Normally, I use 3/4 portal for the scope, then 6R 60 portal for the instrument for radiocarpal arthroscope, then the DRUJ portal for use to foveal region. I normally use 1.9 scope to see the radiocarpal and the DRUJ. In 1989, Palmer classified the TFCC injury class 1 as a traumatic tear and class 2 as a degenerative tear. Then he also subclassified the class 1A as a central tear, class 1B is the ulnar tear, class 1C is a distal tear, which seldom seen in the clinical practice, then class 1D is a radial avulsion. Then his class 1B includes an ulnar styloid fracture or completely detachment of the fovea. However, this is a classification based on the radiocarpal arthroscopic analysis. Then foveal region cannot be seen through the radiocarpal side. Palmer also classified degenerative tear as class 2. Then class 2A and class 2E is depending on the severity of the degeneration of the triangular fibrocartilage. Andreacci further subclassifies the Palmer's 1B region to his class 1 to class 5. Class 1 includes a repairable distal tear, class 2 is a repairable completely tear, class 3 is a repairable proximal tear, class 4 is a non-repairable tear, and class 5 is arthritic DIUJ. Then his class 2 and class 3 was diagnosed by a DIUJ scope. Actually, I did an analysis of my series, then which I found that from the radiocarpal side, I saw a central slit tear, which indicates a slit flap double transverse oblique coronal bucket handle. This only one case has a distal tear, then 5 cases has a radial tear, which includes the one limb tear. Then almost half of the cases shows a peripheral ulnar side tear. Then 10 cases indicate a dorsal tear, completely aversion from the dorsal side, and 2 cases has a palmar tear. Then horizontal tear or degenerative tear was found in the radiocarpal scope. Then from the DIUJ side, the proximal slit tear, radioulnar ligament partial aversion or completely aversion. Then I saw fibrillation of the proximal surface of the radioulnar ligament, then relaxed radioulnar ligament. Then almost 2/3 of the cases is isolated tears. This means single tear. Then 30% has a double lesion. Then 2% has a triple lesion. So you may find that one tear in the radiocarpal side. However, please process to proximal side to find another tear. New classification system based on the radiocarpal and DIUJ-scopic findings will be published in Hamipura very soon. For radiocarpal arthroscopic findings, I actually categorized class 0 to class 4. Class 1 is interdisc tear, class 2 is radial border tear, class 3 is peripheral tear, and class 4 degenerative tear. For DIUJ-scopic findings, I categorize the stage 0 to stage 5. Stage 0 intact, stage 1 slit tear, stage 2 partial radial ligament tear, stage 3 completely radial ligament, then stage 4 proximal fibrillation with radial ligament, stage 5 relaxed radial ligament. It covers all traumatic TFCC regions very well. In conclusion, anatomy shows that TFCC demonstrates three-dimensional hammock-like structure. Proximal component of the TFCC is the radial ligament, stabilizing structure of the DIUJ. MRI and arthrogram are useful to diagnose TFCC injury. Arthroscopy is a gold standard tool for diagnosis of the TFCC injury. New arthroscopic classification system is introduced, which covers all TFCC injury very well. Thank you for your attention. Good afternoon. My name is Toshi Nakamura.
Okay.
I would like to talk about.
Thank you very much, Toshi, for your excellent talk. So maybe I start asking a question. So what questions is I would like to ask how accurate do you think MRI is in terms of determining the TFCC tear?
Yeah, actually, my young colleague actually analyzes to checking the MRI and arthrogram compared with the arthroscopic findings. Then MRI covers almost 80%. Arthrogram covers another 80%. But that is a little bit different. Arthrogram is very sensitive for peripheral 1B, Palmer's 1B tear or my class 3 injury. Then MRI actually is very useful for the degenerative tear or fovea avulsion. That is a stage 3 or stage 2 injury. So those actually do not cover 100%. So that is why we still need an arthroscope to actually checking and also finalize the TFCC injuries diagnosis.
Okay.
So there's one question from the Q&A. Someone asked, can you explain about the attachment and function of the meniscal homologue?
Yeah, meniscus homologue is actually demonstrated by Andy Permer in 1981, and also my first report in 1996. I also mentioned the meniscus homologue, but recently I and David Nelson did another histological study, found that meniscus homologue is a synovial wall of the ulnar side, distal ulnar side of the TFCC, which cannot be differentiated in the meniscus or fibrocartilage area. This only few specimen has a fibrocartilage metamorphosis. So I think that we do not have a meniscus homologue, and then also that ulnar collateral ligament.
So there's another question is, are you using weight-bearing tests to define stability of the TFCC?
I normally using the Barotman test only with especially in a general anesthetic condition or brachial plexus anesthetic condition. That is actually checking the DIUJ instability very well. Then I don't do any load-bearing test on that because some patient has. So we actually have a stability with stability and also stiffness and also laxity. Then some patient has a general laxity on this patient. Then if we load bear on this joint, then in a general joint laxity patient has a severe load displacement by load. So I think that, in my opinion, the stiffness is much sensitive to checking the DIUG instability, and a human hand is very sensitive to checking the stiffness.
Okay.
So in addition to this, will you think if the patient is under general anesthesia and then you test the development test, is it more accurate, or when the patient is still awake, is more accurate?
Yeah, we actually checked with an DIUG stability in an awake patient and the general anesthetic patient. I actually feel that a very unstable patient, but in a general anesthetic condition with grabbing the radius and corpus hardly, and then the grabbing the ulnar head hardly, then actually I don't feel any instability. But in outpatient clinic, yeah, that the patient cannot allow to have a hard grabbing on the hand and hand radius or ulnar. So that is why that there is a discrepancy between outpatient clinical side and also before the operation side. So that is why I normally and always check the DLG instability in a soon before the surgery.
Okay, thank you. I think you mentioned that in your presentation that sometimes there's combined tears. In that case, what do you do? I mean, do you pair them off, or what do you, or how do you decide how to manage this?
Mainly that this kind of double region includes a radial ligament avulsion. So in that situation, actually I repair or reconstruct the radial ligament first. Then when I have enough stability on the of the DIUJ, then I stopped doing. Then if still there is unstable DIUJ, then I do actually adding that peripheral side repair in a capsular repair.
Okay. So would you consider reconstruction in some of these cases, or you try to repair first, if possible?
Yeah, try to repair first, because maybe that later PC or Jeff will talk about this kind of things. But in my opinion, that patient has a chronic situation, still there's a possibility to repair, then I do repair it. Then the arthroscopic analysis cannot differentiate which is irreparable. Arthroscopy can differentiate repairable fibers. When I see fibers, elastic fibers on the radial ligament, I do an arthroscopic transversus repair. However, that if there's a chronic situation, there's lots of scar, then after debridement on the arthroscopy, still it is quite difficult to differentiate which is repairable, which is irreparable. So that is why that I do open it. I checked with the ligament condition with the forceps to bring back the fovea. The ligament can be bring back the fovea, then I do repair it. Then if the ligament was easily detached, then in that situation, I do reconstruct the TFCC.
Okay. Yeah.
Also, I would like to be repaired.
Okay. Yeah. Yeah. Esther? I think
There are
I
some
think
more questions.
yeah.
from the
Okay.
Q&A. So, do you make foveal repair if the ghost sign is very positive, but this is not ulnar allotment?
Ghost sign, yeah, or a suction sign, or floating sign, or peripheral tension, or loss of trampoline test, which is an indirect sign of the fovea avulsion. So if you do, if you are familiar with the diagnostic findings, then you can directly see the foveal region. Then in that situation, then still I do check within an open manner. Then if the ligament can be reattached by a forceps, then I try to do an open.
So what do you think the different signs, the hook test, the ghost sign, and the DRUJ arthroscopy, which one do you think is the most sensitive in diagnosing foveal tear?
I didn't check with this kind of sign because this is an indirect sign, but I think that there may be maybe that 60% to 80% positive. Then, especially if the Fok test, if the distal side of the TFCC is completely intact, then it is quite difficult to see a Fok test positive. But that can be a floating sign or ghost sign can be positive if the ligament was completely torn. So, but if you check with a ghost sign, you must insert and probe into the deep region of the TFCC. Then that can be a possibility to harm the TFCC. So, yes, the seeing is believing. So, I do check with the DAUG scope.
I see.
Yes. Yes. So you check so you do DRUJ scope for all your cases.
Yeah, all of the cases. Actually, I presented in the last IFS meeting in a webinar. Then I do checks in more than 700 patients. Then I only failed the DRG scope in the 5 patients. So 99.6% can be possible.
Okay. Yes. Is there any tips for the audience about how to do the DRUJ scope?
Yeah, it is. Yeah, you must come to my hospital.
So I think there's another questions
yeah.
for Professor Nakamura. What clinical tests are best in diagnosing TFCC pathologies?
Yeah, the development test is, I think, in my opinion, then most of the patient has an DRG instability in my hospital. Actually, I saw my data that 50% has a peripheral tear, then that 70% has a foveal avulsion. That means 67% has a foveal avulsion or peripheral tear, then that may indicate a DRG instability. However, that Dr. Abe's cases, he actually mentioned only 10% has a DRG instability. So that is depending on that which hospital you belong to.
Okay. But
And
when you do the
yeah, in my case, is DIJ instability is my target. So Barotman test is a reliable test.
I think there was a question asking is which position do you do the Barotman test, in the supination, neutral, or prone?
Yeah, that in a neutral because neutral is more unstable position. So it is quite easy to find out that the loss of stiffness. Especially in the spination, this can be stabilized with maybe the configuration of the joint. So if you see the DRG instability in the spination position, that means that the patient has a severe DRG instability. However, in a neutral position, it's to me much easier to checking the DRG instability.
Okay. Yeah. Thank you. And I think there's there's a lot of people that who talk about that in the ECU cases, in the ECU subluxation or tendinitis, they will also have TFCC tear. So in cases where you actually operate on the ECU tendinitis, would you routinely do a risk scope as well? And would you, and if there is a TFCC pathology, would you manage them as well?
ECU's disorders is quite difficult to diagnose. So that is why that the patient has a swelling on the ECU side. Then I do actually inject steroid and with a local anesthesia. Then if it works well, then the patient has an ECU disorders. But also that ECU cyst is a part of the TFCC region. Then I think that some patient has a small slit tear on the ECU cyst floor that can be connected into the DIUJ or radiocarpal ligament through the TFCC injury. In that manner, it is quite difficult to treat. Now, I actually have a patient treated with an ulnar shortening but failed because of this kind of connection between the ECU and the TFCC or radiocarpal or DIUJ. So when I actually repair the DIUJ in open fashion, and I actually always open the six compartment, then that I actually remove the ECU tendon, then I actually diagnose the ECU disorders. But when I do a capsular repair or something, then actually sometimes I misdiagnose or ignore the DIUJ or ECU disorders.
So will you treat the ECU problem conservatively and wait until there's no more ECU symptoms before you tackle the TFCC problem?
Then if the fibrosis band of the ECU, then if it can be repairable, I try to repair. But some patient needs a spinner type reconstruction using the extensor retinaculum. Then that worked very well.
So in those cases, when you operate for the ECU, you always do a scope just to see whether the TFCC is in.
Yes, that is true.
Okay.
This is quite important.
Yeah. Okay. I think there's some more questions, but should we start for the next presentation?
Okay.
Yes.
Thank you very much.
We can just answer the questions by typing. Okay. Thank you.
Very welcome.
Thank you.
Thank you so much. So the next speaker is Dr. Sanjeev Kakar. So he's an orthopedic surgeon specializing in hand surgery in Rochester, Minnesota. He received his medical degree from St. Bartholomew's and Royal London School of Medicine and Dentistry in 1998. Following his medical education, he received his MBA from Boston College. Additionally, he completed a residency program at the Boston University School of Medicine in 2009, as well as a fellowship in hand and upper extremity orthopedic surgery at the Mayo School of Graduate Medical Education in 2010. So today, Dr. Sanjeev Kakar is going to talk about treatment of TFCC injury, my preferred method. So can you please broadcast his video?
Hi, my name is Sanjeev Kakar. It's an honor to be here today, and I want to share with you some tips and tricks in arthroscopic foveal repairs of TFCC injuries. My disclosures are on the ASSH website. So before we dive into the treatment of TFCC foveal injuries, I think it's important to have an understanding of the soft tissue anatomy. There's many ways to understand this. My mnemonic here is Rupert. R stands for the sigmoid notch of the distal radius, which gives you 20% stability of the ulnar carpal joint at the DRUJ. U are the ulnar carpal ligaments. P is the deep head of the pronator quadratus. E is the ECU tendon in its subsheath. R are the radial ulnar ligaments, and T is the TFCC. So if we look at the radial ulnar ligaments, this is a study done by Toshi Nakamura many years ago. The TFCC is a confluence of fibers which has the superficial fibers inserting into the styloid and the deep foveal fibers, which are the primary stability of the DRUJ. And here you can see the foveal insertion of the TFCC. When you think of the ulnar carpal ligaments, this is a prosection by Mark Garcia-Elias, and we're looking at the palmar side of the wrist, and you can see that there's a natural confluence between the ulnar lunate and the ulnar triquetral ligaments. The radial ulnar membrane, more and more discussion is being held about the importance of the distal oblique bundle of the interosseous membrane, giving you stability at the wrist, and also the ECU tendon in its subsheath. So this is a dynamic stabilizer. So if you look at the ECU, it's the only tendon that runs with the ulnar, and when it compresses, it drives the distal ulnar into the sigmoid notch, giving you a dynamic stabilizer of the DRUJ. And finally, it's the deep head of the pronator quadratus muscle in full supination. When this activates, this drives the distal ulnar into the sigmoid notch. So how do you treat this patient? When you see this patient who has gross instability of the DRUJ, is this a bony problem? Is this a soft tissue problem? Is this both? There's many classifications out there. This is a classification taught to us by Mark Garcia-Elias, the four-leaf clover algorithm, where you essentially ask four key questions. Is there a bony problem, yes or no? For example, is there a distal radius malunion that needs to be corrective? What's the quality like of the cartilage? Is it arthritic or not? What is the quality like of the static stabilizers of the DRUJ, namely the TFCC? And what about the dynamic stabilizers such as the ECU? So you go through this as a checklist, and you have to identify what's causing the problem and address all of these. These are not mutually exclusive. One of the things that I want to try and talk about today is also about the acuity of the injury. We're taught that if something is acute, you can repair it, and if it's chronic, then you need to do a reconstruction. I think actually the key determinant is what is the quality like of the soft tissue, and is this able to be repaired or not. This is a nice classification by Andrea Atzi, which basically looks at the quality of the tissue at the TFCC and also where the location is. And through this, you can work out those that can be primarily repaired and those that need to be reconstructed. Now, how do you test the TFCC, especially regarding its foveal attachment? There's many different arthroscopic classification systems out there, but sometimes the TFCC is also scarred in. So how do you assess whether the TFCC is competent or not? Well, what's the hook test? So here you can see in this video, the probe is going from ulnar to radial. You can see that it freely lifts the TFCC off the fovea. So here, this is a positive hook test. What about the trampoline sign? Now this is more subjective, and you can see that there's a natural buoyancy of the TFCC. So this is a normal trampoline sign. What about the suction test? So here's an example here where you turn the suction on and you can see how the TFCC completely lifts off the fovea. So this is either a determinant of foveal detachment, or if there's laxity of the peripheral side of the TFCC, and this is healed by scar tissue. So here you can see in this patient, now we've repaired it. Now when we put the suction test in, you can see that we've restored the natural buoyancy of the TFCC. What about DRUJ arthroscopy? I think this is a critical tool to help you assess the foveal attachment. So look at this case. So this is a patient who had a bad accident. You can see has a distal radius and ulnar fracture that underwent a closed reduction in percutaneous pinning by our pediatric orthopedic colleagues, and you can see has a nice reduction. 4 months later, you can see has a pretty anatomic reduction of the distal radius and the ulnar. But he comes back 10 months later and he has pain and clunking. And look at the gross instability of the DIUJ. Now, when you look at the MRI, if you look at the image on the left and also the axial view, the DIUJ looks to be well located and the TFCC looks to be intact. And this is the MRI read stating that the patient essentially had an intact TFCC. So if we go back to that 4-leaf clover algorithm, the bone looked good, the sigmoid notch looked aligned, there's no post-traumatic arthritis, the ECU was clinically stable, but this patient had a TFCC injury. So how do we treat this? So this is a modification of the technique described by Wei Chen many years ago. So here we're doing a radiocarpal joint arthroscopy, and this patient had a negative trampoline sign and the hook test was negative. Now the mistake here is to stop. Here we need to look at the foveal attachment, and how do we do this? Well, we do this through DIUJ arthroscopy. So the camera is still in the 3-4 portal and the needle comes in underneath the TFCC, and you can see that there's gross laxity. And then the DIUJ arthroscopy starts. And look here, we're underneath the TFCC, we're getting all the way to the ulnar side, and you can see that there's foveal detachment of the TFCC. So now we make a working portal just volar to the ulnar styloid. We're coming in underneath the TFCC with scissors. And now you can see we're using a curette to debride the scar tissue of the foveal insertion of the TFCC. We want to get that fovea insertion back down to the distal ulna. So now the shaver comes in, we're debriding this area. So now we're going to do the arthroscopic foveal repair. So we've made an ulnar-sided incision. We can see the dorsal sensory branch of the ulnar nerve, and a vesi loop goes around this. And now we're incising extensor retinaculum, cheating as volar as we can. So once we've done this, we'll then take the extensor retinaculum and take this dorsally, and then through DIUJ arthroscopy or through the radiocarpal portals, we're basically debriding the foveal insertion of the TFCC, and you can interchange between your portals. Now we're taking a 0.062 K wire, and the beauty of doing this arthroscopically is we can see exactly where the foveal insertion should be, and we're critically actually a little bit dorsal there, so we'll just raise our hand and go slightly volar, and now you can see through the radiocarpal joint arthroscopy the anatomic position of the ulnar tunnel. So once we've made the ulnar tunnel, now we're going to put sutures through this 0.062 K wire hole. So there you can see I'm mobilizing the TFCC, and now we're taking an 18 gauge needle with a loop 2O PDS. It's gone through the ulnar foveal tunnel, and then we're pulling this out through the 6R portal. So once we've done this once, we'll take another 18 gauge needle and just push this slightly volar, and you can see it comes out right at the footprint of where the fovea should be. So as we push the needle through, we'll then shuttle this 2O looped PDS out of the 6R portal. So now we have 4 limbs of suture going through the ulnar foveal tunnel. So we now will cut this, and now you can see we know which suture runs with which. And here we're taking a 20 gauge needle and we're just pushing this through the TFCC. And there you can see we have a suture, a loop suture, which will act as our shuttle to shuttle this stitch back through on itself. So here you can see the grasper comes through the 6R portal. We'll pull this through the 6R portal, pull the needle back so we don't cut the suture. You can use a wire loop for this. And now we'll take one end and shuttle this back. So this suture now has gone through the bone, through the fovea, back out the TFCC. And so you can see we've done this. And now we'll repeat this several times. So here you can see the needle comes back in, and we're pulling it back on itself using this suture shuttle with this PDS suture. You can see as we'll pull this back, this suture has gone through the distal ulna, through the TFCC and back on itself. And you can repeat this several times. So this is our other looped 2O PDS, and we'll repeat this again. So we know which suture goes with which, and then we'll tag these, and once we're happy with which suture then goes with which, we'll then come through with the 20 gauge needle, shuttling this suture back out across itself. So here comes the needle, and then we're going to push this through and then shuttle the suture back across itself. So here you can see the foveal repair that we've done. And now this is all of us taking the wrist out of traction, and we've tied this down. And you can see the immediate stability of the DIEJ by tightening down that foveal repair. And this is just showing the wrist out of traction, having a nice stable repair. So this is the patient 3 months post-op. This is the contralateral wrist. So this is his uninjured wrist. And you can see as natural laxity of the DIEJ. Now this is the one that we operated on, and you can see as good full passive pronosupination. And when he does this actively, you can see he has excellent range of motion. And now we'll check his stability of the DIEJ. So he has a little bit of laxity, but much more stable compared to the uninjured side. And so we're just checking stability in different forms of rotation, and you can see from his viewpoint how his pronosupination is and his wrist flexion and extension. So I could have picked many articles to share with you. If you look at the literature, this is a study out of Japan showing good results at 20 months of follow-up. Another study showing up to 4 years of follow-up, showing good stabilization of the DIEJ. So in summary, I think when you're treating DIEJ pathology, you need to have a classification system. The 4-leaf clover algorithm allows you to sequentially check what's causing the problem. And the key thing is to treating these instabilities and pathologies at the same time, and these are not mutually exclusive. Thank you very much.
Thank you very much, Sanjeev. So I know you are at 5 o'clock in the morning, so thanks a lot for your help. Maybe I'll start the first question. You mentioned about the transosseous tunnel for repair of the foveal tear. So do you have any tricks in putting in this bone tunnel?
Morning, Esther, and it's nice to see everybody. Esther, it's 4:43 in the morning, not 5.
Okay.
Give me an extra 17 minutes of sleep. No, I'm joking. So the technique that I showed, honestly, is described by Jeon, and I would urge everybody to read that article. It's a tremendous article. I think it was published in Journal of Arthroscopy. And our good friend Jeff Ecker had a lovely article in the Journal of Wrist Surgery on DIEJ arthroscopy. So I think those are the two key articles I would urge everybody to read. In terms of technical tricks, Toshi Nakamura, who we all know and love, who's on this, has a very nice foveal repair guide that allows you to make the bone tunnel. I think that works very well. Or I take, as I showed in that video, a 062K wire and essentially have the ulna between my fingers. And the beauty of DIEJ arthroscopy is that you can actually see when you're putting the K wire under oscillate mode, before you even pierce the TFCC, you can see it come up through the ulnar head. And I will cheat slightly radial to the fovea, because sometimes these patients, the quality of the TFCC isn't the best. And if you go right at the fovea, sometimes the suture can actually tear through the actual TFCC. So I'd rather take a bigger bite of the tissue when placing that bone tunnel.
Okay.
So there's a question from the Q&A. Can you let us know the size of the scope, the size of the sutures, and the amount of traction? And do you remove traction when tying the sutures?
All very, very good questions. So I use the 1.9 millimeter scope. There's many out there. I do use the Arthrex nanoscope. I found that actually to be very helpful in these cases. Ironically, it's flexible, which I didn't quite appreciate when I first started using the 1.9 millimeter scope, because traditional 1.9 millimeter scopes are much shorter and rigid. They are, some of them can be a little bit brittle as well. And if you damage that scope, it's hard to find another one. So I use that scope. In terms of the suture, in the video I showed a 2.0 PDS. I've now actually moved to using the 2.0 fiber stick. It's a fiber wire suture, and I found that those knots actually lie a lot flatter and don't stick up compared to 2.0 PDS. Now, it is a non-absorbable suture, but I found that you can close the extensor retinaculum over that, and that's not a big problem. And that's a 2.0 in terms of the suture. Were those the questions, Esther? The scope, the suture,
traction.
traction? Yeah. So because it's a thinner scope, a 1.9 compared to a 2.7 millimeter scope, I tend to use no more than 7 to 10 pounds of traction, usually about 7 pounds of traction.
And also when you tie the sutures,
yes.
will you relieve the traction?
Yes, great question. So yes, I pass the sutures and everything with the traction on. And when I tie the sutures down, I release the traction and I tie it in just neutral rotation.
Actually, about this suture, what suture to use, I also want to ask other panels, like maybe Professor Nakamura, Dr. PC Ho, and Jeff, what kind of sutures do you use for repair of the TFCC?
Yeah, can I answer first? Then I normally use the 3O bicoil absorbable sutures for arthroscopic repair. Then I normally use non-absorbable suture stitches in open repair. So in arthroscopic repair, I do absorbable sutures. In capsular repair or transverse repair.
Okay. Does that change your rehabilitation protocol in terms of what suture do you use?
Yeah, that I firstly use non-repairable polyester Eti-bond or Tycon sutures in our repairs, but I gradually switched to the absorbable sutures. So for the capsular repair, then worked well. Then I actually changed the transverse repair. Then it worked very well. And my patient was obtained the gold medal in the Tokyo Olympic Games in 2021 with an arthroscopic transverse repair.
Okay. Okay. But so for the rehabilitation, do you immobilize them for the same time?
Yeah, actually I put 2 weeks upper arms, 3 weeks lower arm cast. Then patient can allow active range of motion for 2 weeks, then passive range of motion. With loading is gradually up.
So in neutral rotation or in like semi-supination?
In a upper arm casting in a neutral position in the wrist and also forearm, then the patient can slightly rotate after changing to the lower arm casting. But don't fully pronate or don't fully pronate. Always I say to my patient.
Okay. And maybe Jeff? Yeah.
Yeah, look, I use a double 2O vicryl. I use a technique that I'm going to show that quickly in my talk. Rehab's important. We don't go above elbow. We don't use a sugar tongue. The reason for that is we found that there was ulnar nerve symptoms going with sugar tongue. And we also found that there was a slight reduction in the range of motion in the wrist. We go below elbow and start moving in the below elbow splint straight away. And they usually take about 4 months. Or I'll cover that in my talk. We'll do that later. Thank you.
Okay. Dr. Ho?
My preference are 2O PDS. I only change one. When I do my first K 25 years ago, I used a 3O PDS. Then it break. Obviously it break. Then I changed to 2O. And then since for the last 25 years, I don't change anymore. So it's the only type of suture I use all over the years. I think it's reliable, but you need to not 4 times, and then make sure and then you cut it very short, so that you're not causing any irritation. But because it's absorbable, so in 6 months of time, usually all the worry will gone. And also you have to tie very deep into the deep capsule area, and usually there's no problem. Rehabilitation, I use Sugaton cast for 3 weeks after the surgery in neutral position. And then after the first 3 weeks, I changed to a Sugaton brace. Instruct the patient to have some daytime motion. Mainly it's a mid-range of motion. So basically, if they move around 30, 40 degrees of pronation supination, I think there will be minimal strain to the repair site. And then they will gradually increase the active rotation. And usually by 6 weeks after the surgery, I will free the forearm rotation. They can freely mobilize it. So I found the Sugaton are okay. There's no ulnar nerve symptom in my patient. Maybe one have to be careful. Of course, you have to be careful not to be too much pressure onto the other side. But I think people like it because they can move the elbow freely.
Thank you. I think there's a question to follow is when do you allow the patients to do free load and especially to return to sports? I know that you all have managed some athletes, some professional athletes. When do you actually let them go back and resume their sports activities? Maybe to start with Dr. Ho. Yeah.
I think basically the patient has to get at least 80% of the normal range of motion, if possible. Of course, some patients will be forever stiff, but most of patients after TFC repair, they should be able to achieve around 80%, usually by 3 to 4 months time. And then I usually, when I get at least 70% of the range of motion, I start to strengthen them. And usually that will be around the 12 weeks time. So 10 to 12 weeks time. And then after, usually by 4 months or 5 months, the strength will be probably return to 80% or 90% of the pre-injury level. So for depending of course depending on the sport, but if the sport require a lot of the wrist control and strength, I think the safe time for me would be something between 4 months to 6 months. So it depends on the rehabilitation.
Yes, same to me. Bicol lost its strength in 10 weeks to 8 weeks to 10 weeks after the surgery. So that is why that normally the patient will recover, return to the normal sports activity level to 4 months to 6 months after the injury, surgeries. However, that a very elite athlete can return much earlier. So that my patient actually who both of those have a gold medal in the Olympic Games, then they return to the 8 weeks after the surgery. Then they won the World Cup or World Championship in 3 months after the surgery. So it's quite different in the normal patient and also elite athlete.
Mm-hmm.
So
Jeff or Jeff or Sanjeev?
Look, we go below elbow straight away. They start moving straight away. At 6 weeks, they start rehabbing with a comprehensive risk proprioceptive exercise program, strength program. We measure their dynamometer readings beforehand, particularly force plate pronation and supination, and we can get a really good gauge when they're strong enough to protect their wrist and get back to sport. And it varies from person to person, the severity of the injury, whether it's acute or chronic. And that way you can actually specifically train your rehab and their return to full activity and feel confident about it as well.
So our program's a little bit different. I see mainly a lot of tennis players that have this. And so what we've done here at Mayo is that we will actually get the players in our kinematic analysis program before surgery, because many of these players actually have kinetic problems that you can't pick up with the naked eye. So they have dynamic EMG measurements, they have surface cameras, and we actually see their kinematic tennis stroke ahead of time. Once we fix them, I agree exactly what Toshi, PC, and Jeff said. But I found for these elite tennis players, it takes about 6 months to get back to that level of play. You know, they have a special gift that many of us don't, and to get to that level, I think it takes longer. And the rehab, as Jeff mentioned, isn't just about the wrist. It starts from the shoulder down. Many of these patients have poor scapulothoracic strengthening and conditioning techniques. So we really work from the shoulder down. So I found for those patients, it takes about 6 months.
Actually, I want to emphasize the muscle is very important stabilizer for the DRJ. So that's why we have to emphasize on strengthening relatively early in rehabilitation. If we don't emphasize on strengthening, the wrist joint is not able to sustain the stress going through the wrist. And I think this elite athlete has a particular advantage of they have used to do strengthening, and I believe their pain level will be better than an ordinary patient. And also they have a very strong incentive. So that's why that's a part of the reason that these athletes can rehab faster, provided that the surgeon do a good job to restore the stability. Yeah. So I agree that if clinically the stability is good, Of course, during the process, you have to monitor the patient. When they're going through the strengthening and the range of motion exercise, you have to ensure that every time after the passive range of motion and so on, the DRJ maintains stable. If they are maintaining stable, I think that's fine, because the pain is going to be just reflect the amount of the surgical trauma inside, and there was they usually will go away soon. As long as you get the range of motion back and the soft tissue becomes more supple, the pain will usually go.
Mm-hmm.
I have one technical question for Sanjeev. So when the DRUJ is subluxed, will you reduce the joint, and how can you like make sure the joint is in a reduced position before you do the repair and tying the sutures?
Yeah, it's a great question. So preoperatively, I tend to look at the axial view of the MRI, and most of the time the ulnar is dorsally subluxated to the radius. And so when I'm putting that bone tunnel in, if I'm going to cheat, I'll cheat it slightly volar of midline. So in that way, as you tie your sutures down, it actually reduces the distal ulna down. So I found that axial view on the MRI actually very helpful. I would say the majority are dorsally, and if it is slightly in volar subluxation, then I would cheat that drill hole slightly dorsal. But we're talking a few millimeters, we're not going all the way dorsal rim or volar rim. So that's how I would cheat it based on the MRI preoperatively.
Yeah, I think this is quite important question that when I always ask to my assistant to reduce the DRUJ when I do an arthroscopic transversus repair. But in an open repair, it's a little bit different. I saw a fovea region much easier in an open fashion. So I create a bone tunnel precisely to the central region of the fovea. Then I repair it, then suture it back, actually reducing the DRUJ.
Okay, thank you. So should we go for the case?
Okay.
Okay.
Yeah, okay. Yeah.
So we have a surprise case.
Okay, it's not a surprise anymore now that you have showed it.
Okay, so it's a 25-year-old gentleman. He's an immigration department officer, right-handed, good past health. He sprained his right wrist while weightlifting in the gym in May 2021. He had tried some splints, but he has persistent ulnar wrist pain. And then 6 months after the injury, he's referred to us. So this is the initial X-ray, which is remarkable. Clinically, there's local tenderness over the ulnar fovea and the ulnar head. There's a DRUJ laxity. Ulnar cable grinding is positive. Forced supination test is positive. And the issue is subluxable. So I think clinically, there's a suspicious of TFCC injury. So here is the MRI. So as I've asked Toshi, how accurate do you think the MRI is? This is the MRI.
Yeah, I think that's the peripheral region that can be seen clearly in this view. So actually this patient has a peripheral tear, but the fovea seems to be intact in the MRI, but some high signal intensity in some area of around the fovea region, but there is sometimes that this kind of high signal intensity can be positive with fat tissue inside the fovea area, radial ligament. So this patient clearly has a peripheral side TFCC injury.
So I think I can just go on. So in view of the persistent symptoms and the patient agreed for wrist arthroscopy, so as mentioned by Toshi, a allotment test shows very lax DRUJ.
Yeah, I agree.
So this is the intro findings. The trampoline is slightly reduced. The hook sign, however, is not that positive. But you can see there's a peripheral tear as mentioned by Toshi. You are correct. The MRI showed, but the hook test I would say is not very positive. But the ghost sign is quite positive. So I go in for DLJ scope and find some fibrillation of the tissue over the foveal attachment region. So because of the signs and the findings, I go for foveal repair. So I use the Toshi Nakamura guide for the KY. And then I use 2O Bicro and 2O PDS. I use the same technique mentioned by Sanjeev. So I put the two sutures through the intraosseous tunnel, and then additional peripheral repair by just outside in technique. And this is our final, after the repair, the trampoline is restored. So here's the post-op 6 months. The range of motion is restored. And the pain improved from 4/10 to 0/10. And the grip strength is significantly improved from 12 kilogram to 36.9 kilogram. And the quick dash score is much improved from 80 down to 0. So I think this is just to illustrate the patients may have minimal symptoms, but this TFCC repair actually can help these very young and active patients to regain a very good function.
Thank you, Esther. Thank you for the case. I'm just wondering, so do you do anything for the ECU? Because you said it was sublux.
No, actually, before when the patient first see me, there's a subluxation of the ECU, but actually I think it's quite common to have patients to have subluxation of the ECU, and you have to check the contralateral side. So the patient actually has subluxation of the ECU, but it's not the cause of the symptoms. I don't know if other speakers have similar like experience.
Thank you. I think the ECU is really tricky. Sometimes you think it's stable, other times it's not. And we have a high resolution ultrasound in my office, and we check both sides. And that's really the only way you're going to tell, because lots of people have bilateral ECU instability. And I agree with you, Esther. It's a normal anatomical variation for some people, and it does add complexity to your assessment. So if they're the same on both sides, you've done an ultrasound, they're the same on both sides. Clinically, they're not a problem. Leave them alone.
Esther, very nice case, and 100% agree with Jeff about the utility of ultrasound on both sides. Obviously, the clinical examination is key, and PC has a wonderful stepwise approach to examination of the wrist that he's taught many of us. I do want to ask you, though, I mean, I would have done 100% the same thing, but some people, when they're looking at that case, would have thought they had ulnar positive variants, and you mentioned the ulnar impaction. And so you didn't do anything to the ulnar impaction. Can you just explain that? Because I agree with you. Many patients come in with ulnar positive variants, but they've been like that for years, and suddenly something goes. They have a traumatic event, and so I've personally found me doing less ulnar shortenings, to be honest, and seeing how they go. And so that's why I wanted to get your thoughts about why you didn't do anything there.
I think the patient has an ulnar cable grinding positive. Probably is because of the pain over the TFCC, because the ulnar cable grinding will also stress the TFCC, which cause pain, but it's not like a true ulnar impaction, because when I look at the joint, there's no central hole in the TFCC. There's no degenerative change over the like lunate. So I think there's not symptomatic or a very significant ulnar positive like pathology. So I didn't do anything for the ulnar positive variants.
Well, I tend to agree that the surgical management decision is really based largely on the clinical examination, as Sanjeev mentioned. It is always a very important work force for determining it's not on the MRI and even not on the arthroscopic finding, because sometimes arthroscopic finding can also be elusive. So you have to correlate with clinical. So for example, about the issue subluxation, I agree that some patient can have a subluxable issue, but may not be symptomatic. So I think the synergy test, which probably many of you are should be familiar with the resisted abduction while the wrist is in a supinated position, will be quite useful to determine whether the ECU subluxation is the symptomatic or it may contribute to part of the cause. So I believe if there's if the synergy test is negative, that means the patient is not painful. I probably will focus more about the other pathology. For the ulnar impaction grinding, I agree that sometimes in the presence of the peripheral tear, it will be less painful if just a pure foveal tear, because the injury is basically inferior to the TFCC. So usually the ulnocarpal joint is not much impaired. But in Esther's case, we really beautifully demonstrate that a peripheral capsular tear can coexist with foveal tear. And in fact, when there's a capsular tear, it will be expected will be some synovitis within the ulnocarpal joint. So in that sort of situation, you will actually demonstrate both pain on the ulnocarpal grinding together with passive pronation supination. But usually, if I will have to gauge, I think if the degree of the sign, which one will predominate, like when the patient has more pain on pronation supination action or pain on passive pronation supination, that's a thing. If it is actually far more outweighed the ulnocarpal grinding test, then I probably will put the instability as the major concern of patient rather than that. And also, I agree that arthroscopic finding will be very helpful. If there's absolutely no fibrillation over TFCC, actually you will see in Esther's case, the TFCC looks very nice on the ulnocarpal surface. And there's also, I assume there's no contralesion over the lunate side. And it would be nice to also put the DRJ scope so that you can also see the undersurface of the TFCC, which I think is probably in this case, maybe also all right. So that would be in that sort of case, ulnocarpal impaction will probably can be ruled out clinically. So in that sort of sense, you may just leave it alone, just to focus on the repair. Will be the main advice for the treatment for this patient.
Thank you. So thank you very much. Maybe we can proceed to the next talk, and then we'll go back to the discussion.
Yeah. Okay. So our next talk is going to be Jeff Ecker, who is, I think a lot of people have known him. He's from Perth, Australia. He's trained in Australia and then subsequently did hand and microsurgery fellowship in the Oxford University, United Kingdom, as well as a plastic and microvascular surgery in Duke's University of North Carolina, and South California, Los Angeles. He was the past president of the Australian Hand Society, and he is currently the vice president of the Asia Pacific Wrist Association as well. So his talk is going to be on untreated TFCC injuries. What are the consequences? So Jeff, please.
I think you've got my video.
Yeah. So, yeah.
Thank you. Untreated triangular fibrocartilage injuries. What are the consequences? Well, some people can live with them, adapt and have no problem. Others have pain and instability, and potentially arthritis. The untreated triangular fibrocartilage injury, what is the natural history? Well, it's unknown, and it's complex. There are multiple variables. The anatomical location of the injury, the severity of the injury, whether it's reparable or irreparable, whether there are associated injuries, whether it's acute or chronic or acute on chronic. And isolated injuries of the triangular fibrocartilage are rare. We looked at our data and only 13% were isolated tears of the triangular fibrocartilage. So it's part of a global injury to the wrist and the distal forearm. So look, we looked at the different combinations and variations of injury, and there's a vast spectrum looking at the anatomy of the injury, whether the tear is dorsal, foveal, volar, part or complete, reparable, irreparable, acute, chronic, acute on chronic, associated injuries, perilunate injuries, scapholunate instability, triquetral instability, whether or not there's a fracture of the radius, whether there's a malunion of the radius and the ulna, whether there's carpal fractures or a malunion of the carpus. So all these things are interwoven, and all of them need to be considered when we're talking about the natural history, the outcome of a triangular fibrocartilage tear. And it needs to be considered in the context not only of the wrist but the forearm. The distal radial ulnar joint is an integral part of the forearm with pronation and supination. If you have instability of the forearm, it's very hard to use the hand and to function in everyday activities. So here's the anatomical location of the injury. This is a dorsal peripheral detachment with a positive hook test. You can see the deep tear extending dorsally along the triangular fibrocartilage insertion and into the plane between the ECU sheath and its attachment to the triangular fibrocartilage. When it's completely gone, you can see a view from the volar distal radial ulnar joint portal. You can see the dorsal DRUJ portal. You can see that the foveal ligament is completely gone, and the bare exposed bone of the radial aspect of the ulnar style can be easily appreciated. Here's a volar tear of the triangular fibrocartilage. Now these are rare. They're less than 3 to 5%, and they're often associated with triquetral ligament injuries. The question of what is reparable and irreparable, and here you have a large dorsal peripheral detachment, which is irreparable, and this irreparable tear can be the dorsal peripheral extending down and can involve the foveal insertion and can involve the entire insertion of the triangular fibrocartilage as it peels off. So the severity of the injury of the foveal insertion, well, it can be intact, and here we can see a normal foveal insertion. They can be intact but abnormal, and again here they are absent, and this is the slide I showed you before showing the bare exposed radial side of the ulnar styloid, and the foveal ligament is completely absent. The associated injuries, here you can see scapholunate instability and traction, and again it's important to examine the wrist in and out of traction, and here you can see the same wrist with a wide dynamic scapholunate instability with a stretched and attenuated scapholunate ligament. Here you can see triquetral lunate instability, and of course these injuries can be part of a perilunate injury with a floating lunate, and all of these factors contribute to the outcome of the tear of the triangular fibrocartilage. Examination of the ECU is very important, and we have a high resolution ultrasound in our clinic, and it's part of our routine examination because unless you can actually see this, you can't have an accurate assessment, and you need to compare it with the contralateral side. So the anatomy and the location of the injury, the severity of the injury, whether it's reparable or irreparable, the associated injuries, whether it's chronic, acute on chronic, it highlights the importance of a complete and accurate diagnosis when we're considering the outcome of the untreated triangular fibrocartilage tear. So what does a complete and accurate diagnosis entail? It involves a history. It involves an accurate and thorough examination of the wrist and the forearm, and that varies from person to person. For me, it's a positive wind-off test where you forcefully supinate the forearm with the elbow flexed, and you get marked apprehension, or you have a positive radial ulnar ballottement sign. And these tests are specific for pathology in the DRUJ, but they need to be considered in the context of a thorough examination of the entire wrist. By themselves, they can be misleading. Imaging is also another essential piece of the information, but it's not as specific as what we think or what we hope. You can do an X-ray, CT, MRI, and ultrasound and not find the reason, and you can have false positives and false negatives, and in particular, a lot of people believe that the MRI is diagnostic in itself. It's not. It has false positives, false negatives, and in a lot of instances is not anatomically specific. Dynamometer measurements are very helpful, and they measure growth grip, lateral pinch, but particularly force plate, the ability to weight bear on the heel of the palm, and supination and pronation strength. And they're good at the beginning and part of your examination because they give you an index of how this is impacting on people's function. And also, we measure them at 3, 6 and 12 months in all their risk cases because this gives you an insight into the outcome of treatment. So the next thing that you need, I believe, to make a full and accurate diagnosis is dry arthroscopic examination of the wrist. And you need to look at the radiocarpal joint, the midcarpal joint, and the distal radioulnar joint. A hook test defines the presence of a tear but is not anatomically specific. You need to see and probe the foveal insertion. You need to examine the entire wrist arthroscopically, and then you'll have a full information base, a complete and accurate diagnosis. And this is where we should start any form of treatment. We've recently published an article on dry arthroscopy of the distal radioulnar joint and the foveal insertion. And I thank Andrea Atzi for showing me how to do anchor repairs of the triangular fibrocartilage. I did 60 to 70 of these. And to Toshi Nakamura for showing me how to examine the distal radioulnar joint and helping me understand the complexity of the joint. So we have a dilemma. What do you do with an acute injury with a positive radioulnar allotment and a positive wind-off test with marked apprehension? You can splint them for 6 weeks. You can rehab them with a wrist proprioceptive exercise program for 6 weeks. You can measure at 12 weeks. And you're doing this with an incomplete information base. You don't know whether this is going to be effective, and you don't have a complete and accurate diagnosis. So there's an element of hope there. Now, if it's effective at 3 months, then you've solved your problem. And my personal experience is that if you've got a positive radioulnar allotment sign, and if you've got a positive wind-off test, very few are effective at 3 months, and often they learn to adapt and have ongoing problems. If it's ineffective, then you go to arthroscopy for your complete diagnosis and examination and repair. And if they've got these signs, they will have pathology in nearly all cases. Then you're looking at a 16-week recovery period. They're in a splint for 6 weeks, they need rehab, and our measurements show that they don't peak and reach their recovery for an average of 4 months. So you're looking at a total treatment path of 7 months. If you go to immediate arthroscopy, examination, repair, and obviously they've got the clinical signs, they've got radioulnar allotment, they've got a positive wind-off test, their dynamometer measurements support this, then you have a full information base on which to base your treatment, and you can either stop there and discuss it with the patient and then decide whether you're going to treat this operatively or non-operatively. But what I've found is patients get very irritated with this, multiple operations instead of one, and nearly all of them will want to proceed to immediate surgical repair. And if you do this, you're looking at a 4-month period to the end result. So what are you talking about? This is a technique that I learned from Toshi Nakamura. We probably don't do it as quick or as fast as him, but this is real time. This repair, this dorsal peripheral repair, if you've got a foveal insertion that is intact, is quick, it's fast, and providing you don't pick up a tendon, the complication rate is extraordinarily small. So the question is, why wouldn't you repair it if it is torn? The complexity increases though when you've got a complete irreparable tear, when you need a tendon graft. And this is rare. It's less than 3 to 5% in our group have irreparable tears of the triangular fibrocartilage. So this is relatively rare. And this is something you do as an elective secondary procedure, and somebody else will be talking about this today. So what do you do when you've got a distal radius fracture that you've arthroscopically reduced and you have a free-floating triangular fibrocartilage with a deep peripheral tear? Well, again, it makes sense to repair it, but this is contentious and we need more information to solve this problem. But I myself will repair the triangular fibrocartilage, and I have the impression that it's less pain in the distal radioulnar joint on the ulnar side of the wrist after the fracture. What are the consequences of a tear of the triangular fibrocartilage? Well, it depends on the diagnosis. Is it missed, delayed? Is the diagnosis incomplete, complete? What about the treatment? Is it delayed? Is it incomplete? Is it incorrect? All of these things can result in disability, and the disability can be quite marked in the impact on people's activity of living in daily life. There's a psychological impact. If somebody has severe mechanical pain or mechanical pain in the distal radioulnar joint in the ulnar side of the wrist and they can't use their forearm and hand, and they go to the doctor and say, look, I've got a problem, and they say, well, your MRI is normal and there's nothing wrong, they're not heard. And if they're not heard, the impact can be very disabling. And especially if you don't fix people within 6 months. I have this figure of 6 months in my head, but if you don't let people see the end of the light at the tunnel or get them fixed within 6 months, they start to have significant psychological impacts, particularly if they don't have the skills to adapt and manage. The inability to work, either in the short term or the long term. Some of these people will never get back to labouring. So the literature doesn't answer these questions. So what do you do when the literature doesn't answer these questions? Well, you look at your own data, and this is what we've done to find some of the answers for this presentation, and you can collaborate with your peer group, which is what we're doing now. So what are the consequences of the untreated triangular fibrocartilage injury? Well, it's a complex problem because we simply don't have the information we require to answer the question clearly and definitively. We know that the triangular fibrocartilage should be considered as not only a part of the wrist but of the forearm. It depends on the anatomy of the tear, the severity of the tear, the associated injuries, whether it's acute, chronic, or acute on chronic, and the natural history, which is very difficult to know. I mean, we can talk about the group and the impact on the group of people we're treating, but what we're really dealing with is how is this going to impact on the individual, and we need to tailor our treatment and our decision and our choices for the individual and include them in that process. Thank you.
Thank you very much, Jeff. So maybe I asked the first question. Although it maybe is not too much related to your lecture. If there is some osteoarthritis change in the DRUJ, and there's a definite TFCC tear, will you still consider repairing the TFCC to see if the symptoms improve before you consider tackling the osteoarthritis?
Look, that seems to be a relatively rare problem in my practice, and I treat a lot of wrists. I mean, people have DRUJ arthritis, got DRUJ arthritis, and repairing the ligament just isn't going to help. You know, it's only be part of a solution. However, when there's a minor degree, or, you know, there's cartilaginous damage and it's not too bad, then I would probably repair the triangular fibrocartilage as part of the whole wrist, because there are no really good treatments for severe incapacitating osteoarthritis of the distal radius on the joint. And that's another question in its entirety. I'm happy to go there if you want to, but that's the way I would approach it.
Yeah. How about if there is an ulnar impaction syndrome and then there is TFCC tear? Would you do, yeah?
That's a great question, because if you do look at, first of all, with ulnar carpal impaction syndrome, it's a wonderful way to look at the anatomy of the wrist, because the triangular fibrocartilage gets pulverized and you can actually see the anatomical components separating. But if, you know, in my experience over the last few years, when you're really looking at these things critically, when you do your ulnar shortening osteectomy, there's frequently an unstable floating triangular fibrocartilage. And what do you do with that? I repair them simply because of how I showed you that technique I learned from Toshi. It is so simple, it is so quick, and the complication rates are so small that it makes sense to debride it and repair it. But this is an opinion, okay? 10 years ago, I would have just done the ulnar shortening osteotomy, done the chondroplasty, left it alone, and thought I was doing well. I don't have the measurements to support it.
Okay, thank you. Yes. So you would do the ulnar shortening first. So you go to the wrist arthroscopy, and then you see that there's impaction, and then there's a tear, and then so you go down and do the ulnar shortening, and then you go back and do the repair. Is that what the?
No. Basically, if you're doing an ulnar shortening osteotomy for an ulnar carpal impaction, you know the diagnosis before you start. There are rare occasions where you don't pick it up on the MRI or the CT, and you pick it up arthroscopically. But predominantly, you have that diagnosis, it's all set, you've cleared up everything else, you know all the other pathology in the wrist, you've done a full assessment. I do the ulnar shortening osteotomy, and then I look in and I check the triangular fibrocartilage. And I do this is off topic a little bit, but in my world, I actually do the shortening osteotomy, then scope, and then check out everything, do the chondroplasty in the ulnar quadrant of the lunator, and check out the rest of the wrist and repair what's left if I need to. Okay. All in one hit. All in one hit.
Okay. Yeah.
So there's some question from our friend Wei Jen Chen. Do you think untreated isolated TFCC foveal tear with DRUJ instability would lead to DRUJ arthritis in the future, or related to the development of ulnocarpal impaction and arthritis?
Oh, look, Wei Jen, that's the real guts of this talk. Thank you for that question. We don't know. The fact is that if you really look at your data, I mean, I've got a patient, I desperately look for the video for this talk, who's got gross instability and is functioning extraordinarily well without any symptoms, that turned up with his partner in my clinic. So we know for a fact that there are some people that can have instability in the forearm and can function incredibly well. So you're not going to treat anybody that's functioning well that has no symptoms. The question of does it rise or result in arthritis in the distal radioulnar joint? Well, intuitively, you would think yes, intuitively, but there's no data for it. So at the end of the day, you should never treat anybody because something's going to happen in the future if they're asymptomatic. If they're symptomatic, the problem resolves automatically because you've got your measurements and you're treating the problem. The real issue is if they're asymptomatic, do you treat them to prevent arthritis in the future? I don't think we have the information for that. And that's such an extraordinarily rare circumstance that you have to face that it's almost non-existent.
How about like some strengthening of the muscles can help this like instability of the DRUJ such that they will not proceed into a very severe arthritic change?
Well, well, first, we don't know they're going to go into an arthritic change, and there's a big difference between the joint that is unstable and the one that is statically subluxed. The statically subluxed is another problem. I mean, that's a completely different beast, and we touched on it briefly beforehand. If you've got a partial tear and it's not complete, it may well heal no matter what you do. We don't know that. We don't know that. You know, it's a minor tear with, you know, and they've got minimal symptoms. They can adapt, they can adjust. They may not need treatment. We don't see a lot of those, okay? But the people that I see, okay, are symptomatic, and they've got a radioulnar allotment test, they've got a wind-off test, they've got all the signs, their dynamometer measurements are off, you know that they're disabled. Well, then that becomes a choice. The choice, it's an informed choice between you and the patient. I mean, you can tell them, look, you know, you may or may not recover. You can tell them if we treat you non-operatively, or if we treat you but simply by therapy and exercises, hoping that you can adapt and your body can readjust and balance your arm, then we'll know within 3 to 4 months what's going on, and it's their choice. You get a pretty good inkling because there's not one or all. The severe end of the spectrum is going to go to surgery because they're grossly unstable. It's the ones that are relatively minor. And it's also the age, the physical demands, what they need, how much time they can take off, whether they're compliant with their therapy. You know, this what's made this talk particularly challenging, all those variables.
Yes. Yeah, I think that goes back to the question that was in the chat box, is there any place for conservative treatment in TFCC injuries? Basically,
well, I think it depends on you have to, as I said in my talk, you're looking at an entire population TFCC or the individual. I mean, if they've got minor pain and they're 65 and they're not laboring and they've got a negative Ballotman test, or their Ballotman test is really subtle and they have no apprehension on their wind-off test, of course there's a place to treat them and wait and see how they go and give them an exercise program. However, if they've got a gross instability and they've got a massive wind-off test and they're following you around the chair when you do it, they're not going to get better. That's my opinion. So you just have to use your judgment. And unfortunately, there's no way to get that information from the literature. Okay. And that's why I said, where do you go with this? I mean, these are problems that I was asking 5-6 years ago. You start measuring. You measure, you look at them. The dynamometer measurements beforehand are invaluable because you can follow them up for 3 or 4 months. And you know exactly what they're doing, and you have to follow that patient. So that's the way I approach it. There's no right or no wrong here. We've got to remember that some of the operations we do make people worse, and we don't want to add an iatrogenic component to it. And that's what I guess we're hedging around. You want to make sure that if you do something to somebody, it's better than if you leave them alone. And sometimes it's a gray area.
Yeah.
think we all have like experienced some patients have persistent pain after TFCC repair. So there's a question from the floor that it seems that repairs are rare. So what are your thought processes for sorting out recalcitrant post-op pain?
Yeah, look, the first thing is that they're not behaving normally. Okay, you know that if you've got the diagnosis, you know that if you've got the TFCC tear, you know what the severity is, you know what your technique is to repair it, you know if there's associated problems, then theoretically they should be behaving along what you would expect. It's the ones that don't that have the severe pain. Now, the ones that particularly stand out in my patient population, and that will vary from country to country, is the workers' compensation middle-aged person whose response is significantly down, and before their final impairment, they can't lift up a carton of milk. But occasionally you'll run into people that have pain. Now, the first thing is you can pick up a tendon, and we have a high resolution ultrasound. We've developed techniques to reduce that. Picking up a tendon is very, very small if you do the technique right. You can even pick up a dorsal branch of the sensory nerve if you're unlucky. So that the question is to make sure that you haven't got a technical error with your operation. The second thing, obviously, is that any operation has acute complications. You've got to exclude those. But when they're turning up at 3-4 months and they're not getting better and they're worse, then they are a real challenge. You have to go back to square one. You have to look at everything, your clinical examination, repeat your imaging, and sometimes you need to scope the wrist. So, you know, the real question is, was it an incomplete diagnosis? Was it an inaccurate diagnosis? Did you make a mistake with the operation? Did the operation fail? Has something else happened? So everyone has its own flavor and its own challenge. And you just have to approach it that way and look at your dynamometer measurements and just look at your patient.
Yeah, I agree. The dorsal branch of the ulnar nerve is a very tricky thing. We have to be careful.
If you hurt it, it is. And you know, that ED, since if you use the 6R portal to instrument, it's very rare that you're going to do any damage or pick up the extensor digitorum minimi. And it's pretty tough to pick up the ECU, but you can pick up the dorsal branch of the radial nerve. And I've got a few videos of those, and it's pretty shocking. You think, well, I'm just going to put the scissors in, cut it, and let the stitch come across. If that stitch doesn't come across, be very careful about what you're cutting, what you're pulling, and make sure you do it. It's so easy to replace it. So, the dorsal sensory branch, if you hurt that and they've got neuroma pain, that's difficult. A lot of people can tolerate it. A lot of people manage it really well with a desensitization program, accurate information. If it's explained to them what the natural history of that problem is, they can deal with it. But we all live in dread of the patient that comes back with the severe burning pain, And what do you got? You got lyricy, you got desensitization, and you just got to sit there and hang on to it and hope it settles. It's not much fun.
Good. Thank you so much. So I think we should proceed to the next talk. So the next speaker is Dr. P.C. Ho. So Dr. P.C. Ho is the Chief of Service of the Department of Orthopaedics and Traumatology in Prince of Wales Hospital. He's also the clinical professor of the Chinese University of Hong Kong. So as we all know, his main interest is in hand and wrist arthroscopy. So he was the president of the HKSSH in 2008 to 2010. And he was awarded the Whipple Prize for recognition of his distinguished contribution in wrist arthroscopy surgery in 2012. So in 2015, he was appointed the president of the EWAS, and he was the founding president of the Asia Pacific Wrist Association since 2015. So without further ado, may I invite Dr. P.C. Ho to present his talk, When TFCC is Irreparable, What Can I Do?
Thank you, Esther, for your very kind introduction. I'm very honored to be able to be invited to this very special webinar today, and also particularly together with many of my great friends and experts in this area. So I think we have heard a lot about the great talk. I was the last one to talk about if we are really dealing with something that we think the TFCC is not repairable. So what can I do? Basically, I will be focusing on one important technique that I think is useful. It's about the TFCC reconstruction using telegraph, but of course with the arthroscopic assist way. I think this is classification by Andrea is very familiar with us. And he emphasized about the class 4 and just a non-repair repair. One can consider some reconstruction with tendon graft. But actually, as we heard about a couple of talk before, that it's actually quite difficult to decide when the TFCC cannot be repaired. As you even heard about Toshi, that even you visually, the arthroscopically, you can see the remnant of the TFCC, it may not be totally reliable. And so you need some sort of dynamic assessment that would be actually, I totally agree, it's actually not often easy. So you actually have to combine a couple of factors, not only the clinical signs, symptom, the history, the duration of the tear, the degree of instability, arthroscopic finding, and I think everything would help you to make a final decision. In general, the concept there will be some tear of the TFCC in a situation where it's very difficult to put them back together, such as very massive rupture of the TFCC, or after you debridement, you find that the gap is really huge. It's very difficult to pull the end of the tear to the original position. And even sometimes the remnant may be very friable and it's very difficult to hold stitches. And sometimes you may actually have done some repair, but that is actually a very common situation. If after repair, but actually the symptom recur, and you find that actually the TFCC may become very floppy, and in fact somehow is already they are intact, but they may be actually elongated and attenuated. So failed previous repair that will be from a good indication, and actually Ricardo and also Andrea also some comments. Sometimes you can see some congenital dysmorphism of the styloid may also predispose to non-healing of the acute repair. So it will continue to be a controversial subject. Anyway, when you're dealing with this chronic instability, in the past there has been a couple of surgical options. Either many years ago, talk about some non-anatomic reconstruction, such as by the Watson or by the Linscheid way, or in the earlier 90s, there are also some sort of so-called anatomical reconstruction, but in fact, it's actually not that anatomical. So we know that the Brian Adams is actually the one has carried out some anatomical laboratory studies to show that all the non-anatomical reconstruction probably will fail to restore the normal natural joint stability. And now we all know about the Brian Adams procedure. Actually, this procedure was first published in 2000, and everyone is kind of simulating the original anatomy of the triangle fibrocartilage, in particular the radial outer ligament, to reconstruct the primary stabilizer of the DRJ. But of course, you can argue that whether we should call it Adams procedure, because back in the 1983, Dr. Mansey in French is already published a similar concept. So no matter what to say, I think currently this is still a very popular way. I have been thinking about arthroscopic technique. Actually, my idea was actually back to 1995 when I started. It's still in my early year of the arthroscopy experience, but at that time I was already dreaming of something like you can arthroscopically reconstruct the TFCC. So I've been thinking for a couple of years. I think it's still technically feasible, and if you can do arthroscopically, there's an advantage because you can evaluate the TFCC under the very good environment, and then you can make a decision. And when you have a least destruction to the DRG capsule, often you can have maximum preservation of the motion. Particularly when the patient after the surgery, they lost some sort of pronation because of the scarring over the dorsal DRG capsule. And overall, when there's a less surgical trauma, the rehabilitation probably can be favored. So of course, when we do minimally invasive surgery, we have to respect all the anatomy. So that's why it is a minimally invasive surgery. But if you do not respect the anatomy, you may become maximally invasive. So with the small incision, we have to understand what are the structural risks. So basically, we are using kind of the 3 incision approach. Dorsally, we approach between the extensor tendon and the EDC and the EDM. And then on the volarly, we go between the junction of the flexor tendon, median nerve, and also the ulnar neural subundal. So that will be a type of typical incision. And then on the ulnar side, with these 2 dorsal volar incision, basically we can quite control the radial tunnel. And then on the outer side, we follow the ulnar shaft and then go towards the fovea region. So basically, we are developing bone tunnel according to, and in order to avoid a damage or accidental cracking of the articular surface, we have to ensure that it's a few millimeters from the articular margin, both distally and on the outer border. And one trick is actually the tunnel, the exact tunnel will be just distal to the PQ. So on the volar incision, right, just distal to the PQ and in between the ulnar nerve and also the flexor tendon. And then you can actually we get the right tunnel. The tunnel size is basically is a 2. We start with 2 millimeter drill and then with 2.5. In the Asian hand, I think 2.5 millimeter is very good for very good for the palmar longus tendon graft. We use all the time, most of the time. The ulnar head tunnel is probably the key for success because you have to make a good tunnel. You have to aim for the fovea. And the exit is about 12 to 15 millimeter from the tip of the ulnar styloid. And you can verify under arthroscopic monitor. And also, so usually under arthroscopic, you can actually see the KY was exit. Be careful, the KY is very easily hit onto the carpal bone. You have to do something to protect it. Usually I use a hemostat and then grab the end of the KY to ensure that the subsequent drill will start with 2 and then finally usually end up with 2.9. This tunnel has to be larger because we have to pass the graft 2 times. So this has to be larger. But again, something less than 3 millimeter will be usually good enough for the Asian hand. So this is the typical tunnel position in say in the MRI. You can actually see the fovea tunnel and also the radial tunnel. So then I usually with the volar incision, I take the palmar longus graft as my graft. In patient where your palmar longus is absent, you can also using the split CR if you want to same upper limb, or using a Pantaris facial in general incision. You can also use a Pantaris. Of course, you can also use palmar longus of the opposite side, but against when the palmar longus is not pleasant, you have to think about that. And so this tendon graft was delivered through the radial tunnel, which is usually easy part. You deliver from the dorsal to the volar aspect. And then the graft will be retrieved back into the joint. Usually using a 2 millimeter grasper, you can deliver the grasper from the volar capsular window through the 4-5. Of course, you have to be careful not to catch the neurosacral bundle and the flexor tendon. And then when this tendon was going back into the joint, then the other grasper can be delivered from the outer tunnel to pull the tendon exteriorize from the joint to the outside. So you can see that inside the joint, you can using a small grasper to pull the tendon back into the joint. And then the second grasper from the outer tunnel, you can actually pull it. So at one go, one limb of the tendon graft can be already delivered outside the joint. And then the dorsal limb also has to be returned to the joint, and usually they go through this, the 4-5 portal. But when you return the graft into the joint, ensure that it is underneath everything. That means you should not grab onto the extensor retinaculum. You should not grab onto the EDC, EDM tendon, and also the dorsal sensory branch. And so you can see this actually when the tendon go back into the joint, it's also overlap with the external capsule and also the outer carpal ligament. I think is a kind of augmentation to this or 2 original ligament. So then finally, another grasper 2 millimeter in size can be delivered from the outer tunnel. And you can see that the volar limb, the dorsal limb of the tendon graft can be delivered through the same tunnel. And you can see this 2 tendon can be nicely delivered into the joint. And you can see the 2 limb then exit outside, the wrist over the outside. We will do the maximum tensioning with the form in neutral position. And usually we will find that the palmar longus tendon is not long enough to grab the wrap around the outer neck, which has been first described by Brian Adams. So usually we find that it is more easier to make a transfer tunnel just slightly proximal to the exit area of the ischial tunnel, and then you can use one limb of the tendon graft to passing through this transfer tunnel, and then you can tie the very secure lock. The tiring was when the tension is completely off the traction and the form is in neutral position. And when you complete tie, usually we'll tie 2 knots and then we're passing every bond non-absorbable suture to that. And you can see after this tying, you can test the rotation motion is actually very nice. They're in the isometric position, so the tendon graft will maintain in the good position while you're not jeopardizing the motion. We're using this reverse circuitron task. By fixing the epicondyle area, we restrict the pronation supination. You don't need absolute immobilization. I think some you'll be good enough to be to serve the purpose. The cast was maintained for 3 weeks and then changed to the reverse supinaton splint, carry for another 3 weeks, and then subsequent short arm splint. So we will start the mid-range motion at the beginning of our 4th week, and then till 6 weeks, we will then usually we allow full active range of motion. The passive range of motion start around 8 weeks, and then strengthening usually 8 to 10 weeks time, depending on the program patient. So here's this publication of a couple of years ago. We published about 28 patients. As I mentioned, again, we do not do this surgery too often. I agree that most of the case can still be repaired, but in fact, there are indications where you can actually also perform the reconstruction. This patient, a typical young patient, demanding case. Some of them are work compensation. Many of them has previous surgery, and the median duration symptom is 21 months. So they're actually quite chronic case, sometimes up to 20 years old. And we follow the patient for quite long, average of 5 years. So the indications are including some of the traumatic peripheral TFCC with very large defect irreparable, or failed previous TFC repair, or ulnar stellar non-union with overt DRG instability, or chronic DRG instability that more than 1 year, where we think that the potential for healing will be less. And sometimes in some rheumatoid patient, relatively selected case, non-active disease inside, but significant DRG instability, and very young patient, we will also perform this reconstruction. But in anyway, in all cases, we have to rule out skeletal malalignment, such as a malunion of the distal radius or the ulnar, or in arthritis of the DRG, or form axial instability. Because I think these are the relatively contraindications for this reconstruction. We may have to deal with the skeletal alignment first, before we should cater for the soft tissue. Or when there's excessive arthritis, we may have to go for the salvage procedure. So here's one case with the ulnar stellar non-union. Initially, we do a fixation, but it ends up into a persistent non-union. Because of ulnar plus, we actually try to first do the ulnar shortening. But on table, after the ulnar shortening, the DRG stability is still similar. So then we proceed for the reconstruction by using the bone tunnel in the radius, and then we pass to the ulnar, as I mentioned. As you see in this case, actually we have an ulnar shortening play on, but because of the persistent instability, we just proceed on the same surgery. So sometimes I think the decision making can also based on the clinical finding during the surgical time. So this patient actually has a very nice outcome at the end. Here I show the first case. Actually, I started the reconstruction. It was actually back to 2000. It was a case of very extensive TFC tear, dorsal extend to the ulnar region. We try repair for 2 times without success. Each time we just see the tear become more extensive. So I start to think about this concept using the reconstruction. Here we take a typical bone tunnel, and I believe this is perhaps the first video. At least in my hand, that is, we can see the tendon graft passing from the joint out of the wrist joint. So I think this is a very exciting moment, be able to pass the tendon graft inside the joint. And we have a very good rehabilitation. The first case was very nice. You can see at 4 months time after the surgery, the patient has already gained almost a full range of motion, and the tunnel position is quite nice. They did within the time test. Yes, this is almost 19 years after the surgery. The opportunity to have the patient coming back to examine the patient, you can actually see still maintain a perfect kind of range of motion, and all the physical examination was actually pretty normal, and it's a very good strength. Radiologically, you can see the bone tunnel after so many years, and the actual patient has some back pain. He's using a clamp, but you can see there's no problem for the wrist. So the result is quite reliable. And then the other patient, 20 years at the time of presentation, she has already experienced painful instability for 9 years. So because of the chronicity and also very significant pain on clinical examination, you see this patient resisted pronation, very painful. If I use my hand to manually stabilize the DRG, the patient has less pain. If I remove the stabilization, the patient feels pain. For me, this is a strong indication for stabilization. Because if you add stability for the distal radial joint, you be able to regain the function. So I performed surgery. In this case, actually, you don't see the tear, but the whole TFCC is very floppy, very typical, very chronic, chronically attenuated TFCC. So in fact, I make a central perforation using radio frequency, which is very useful. To make a central perforation enable me to pass the tendon graft through this hole from the outside the joint, and then through the outer tunnel, we can actually pass it through, create an anatomical reconstruction of this radial outer ligament in an anatomical way. So you can see immediately after the surgery, full range of motion can be achieved, but without compromising the stability. So the endpoint was very strong and stable. So this is a case after 13 years. Actually, so just come back this year about last month. I saw the patient. Actually, this patient a documentary every time. You can see that, nice. Excellent range of motion, no deterioration over time, no pain. The DRJ at the end of pronation supination, I always perform the Boltzmann test. I think it's very important to do the stress at the end of the pronation supination. The patient actually no pain, and you can see the bone tunnel in time, which is also has no major changes. So I think this is a good result. So on the whole, this is the summary of the clinical result of the 28 cases. They usually got a quite nice improvement in all the parameter. You can see actually one advantage is the preservation range of motion. This of surgery, you can actually retain up more than 90% of the pronation, supination arc of motion, and there are also a substantial improvement in the function. Like any free surgery, there will be complication. We have to be aware. We have one patient of breaking of KY because sometimes when you actually insert the KY, you have to be careful. Like this case, it's quite unfortunate. The actual KY is broken. So it can be quite difficult to remove the KY, but fortunately, part of the KY is still inside the joint. So I tried to using some instrument to push the KY back. So basically, it can actually back out from outside. We can actually retrieve the KY from outside the joint. So very luckily, sometimes it can be very difficult. So be careful when you're using KY. Some patients have a sensitive ulnar scar because I think the ulnar sensory band is still quite close. You have to be careful. Actually, we have some case with ulnar nerve neuropraxia and even entrapment actually we described. 4 patients actually recurrent instability. Still, they can recur. They tend to rupture around 10 to 18 months time. 2 is because of re-injury. And then we actually have 2 patients to regraft them. 1 patient actually, when we perform a quite complicated procedure, because actually in this case, actually we also perform the SL reconstruction. So because of complexity, we overlook this complication. Actually, the graft, when we return back to the joint, it's actually grabbing onto the ulnar nerve. So we only know that after 3 weeks because the patient has developed severe ulnar necrosis. So actually we explored again and actually found that the graft was just grabbing on the ulnar nerve. So we immediately divide the graft and then release the ulnar nerve. But fortunately, after 4 weeks, the tendon graft is already quite stable. So we don't need to revise the reconstruction. So I can actually reassure that the tendon graft actually healed quite nicely. So be careful not to do that. So this technique has been developed for almost more than 20 years. I think recently there are also some surgeons trying to make some further improvement, like Dr. Kakar in Spain. He actually developed some all inside techniques. Basically, there are no need to create portal outside, and all the instrumentation was inside joint. And they actually, one advantage is actually bring the tendon graft right over the distal end of the femoral node, which suppose is the origin. Andreas also developed a similar technique, but he actually using the counter incision over the radial side to bring that. I think that we will have to see the potential, because this surgery potentially has some advantage for the conventional surgery, but there may be a complication such, for example, intraoperative fracture. I think we have to be carefully avoid. Finally, I think we do expect some recurrent case. We have to manage this difficult case. This is one of the cases that I managed earlier in 2005. She has an injury 20 years ago. So she has a very chronic instability for 20 years. So clinically, just like most of the patients, the pain has a quite painful and impressive pronal supination. The DRG is markedly unstable. And she has the exacerbation because she has 4 months before the presentation. We try splint and physio, just like every patient. We actually try all the conservative management, but marked instability actually will guide you to consider surgical treatments probably early on. Somehow for this chronic case that the MRI may not be very useful. So actually we proceed for arthroscopy to find that they actually, apart from the very unstable joint on attachment with the patient anesthesia, we can also see a very central tear. Of course, it's not the reason for the instability, but the peripheral also has complete loss of the trampoline feeling. But just like many chronic instability, you don't really see the hook side. They're not, because everything become attenuated, very, very elongated, unstable. So we decided to proceed for the this type of surgery. So you can see the two limb was nicely placed inside the joints, passing through the outer tunnel, and intraoperatively very, very good stability. So I'm very actually happy with the surgery. It was done in 2005. The patient was pain-free for 1.5 years, but then unfortunately she had a second trauma after 1.5 years. And initially we conservative managed, but in spite of the conservative management, she continued to painful for another 1.5 years. So I think we cannot wait. We have to look at the joint again. So we do a second look at arthroscopy in 2008. Again, you can see intraoperatively the recurrent stability. And actually we found that inside the synovitis, we found the dorsal limb is still present, but the volar limb is completely disappeared. So I believe maybe the volar limb may have been ruptured in this case. And the patient clearly recorded when the wrist is stable, she is very happy. But when the wrist is unstable, she have the pain again. So we discussed about, so what's an option? Shall we continue to splint, or should we do ulnar shortening? Because she actually also got an ulnar plus. Should we do revision TFCC either openly or arthroscopically, or we just go ahead for this salvage procedure like SK, direct procedure, or even at that time there's the DRG procedures. So after thorough discussion, finally we make a decision. We will try the reconstruction again because patient is still feel confident about reconstruction. But this time, because of the rupture, I think I want to have a more secure method. So I decided to do a double bundle reconstruction. By means of double bundle, I mean we will reconstruct the deep fiber as the original design, but I also try to reconstruct the superficial fiber. So using two tendon graft, the same radial tunnel will serve, but then the one tendon graft will go through the original fovea tunnel, but the other one we will just grab around the outer styler, simulate to the natural anatomy of the superficial part of the TFCC. This time I'm using the PL graft of the opposite side and also the plantaris graft from the foot. So you can see that in this video, I am putting the deep fiber using one of the graft passing through the outer tunnel. Now this also nicely, we just using the original tunnel. They are still pleasant after some clearance. Then I'm using the superficial limb using a hemostat, just pass around the ulnar styloid, and then I grab onto the tendon graft, and the tendon graft can be actually passed on either side of the outer styloid. So basically, it is kind of simulating this superficial branch. So now the DRG was basically been controlled by 4 tendon graft limb, and this was been fixed outside the ulnar, and then using just this sort of it's just like a shoe, ties like a shoelace. You can see that stability is very strong. This is 5 months after surgery. The patient has a good clinical recovery, a very good range of motion, stability well. And you can see actually the grip strength steadily improve after the further stabilization procedure. What about the timing? This is another 13 years just against for this year. So you can see interestingly, radiologically, because of the 2 tendon graft, there's some scalloping effect over the ulnar, presuming it's because of loading effect. But again, the patient clinically still maintain nice, excellent function, full range of motion. Clinically, I always repeat all the stress tests to ensure the patient is stable in all positions of the forearm. Pronation, supination, they are stable, no pain, full range of motion, and also try to test the resistant confrontation by resisting pronation and supination, and also all the carbogranin tests, they are pretty good. I also perform another case in a patient with a high demand. This is a martial art athlete, very elite athlete. He has a chronic instability for 5 years. So for this case, actually, I perform a primary double bundle reconstruction, knowing the demand of patient. So this is about 10 years after surgery. You can see that the X-ray result and the clinical function is also very satisfying. The patient is happy with this surgery. So in summary, I think the TFCC injury, although we largely, most of the occasion we will do repair, but we have to admit that some chronic tear may not really respond well to repair. So we have to preserve some other technique to deal with this problem. And I think arthroscopic assisted reconstruction with tendon graft is technically reproducible, safe, and desirable rehabilitation. And it can allow you a total anatomical reconstruction in respect of the direction and instability, and then our results show the good long-term outcome. And double bundle reconstruction can be utilized for recurrent case or highly functional demand case. Future research still on the long-term graft viability and the bone tendon junction healing to reduce the recurrence. So thank you very much for kind attention, and I would like to entertain any questions and a comment from all of you. Thank you.
Thank you very much, Dr. Ho, for the excellent talk. So maybe I start the first questions. Have you encountered any case of fracture of the distal radius or the distal ulna after this TFCC reconstruction?
Yeah, thank you. I think this is something that we have to actually cautious about. For this reason, I advocate you using small tunnel, which is just enough to pass the tendon graft. So as I mentioned, the radial tunnel 2.5 is very good for most PL. And then for the outer tunnel, I believe 3 millimeter would be good for Asian. And I actually, in my series, touch wood, we don't have any fracture case yet. But I believe I know some surgeon has actually reported a fracture case, and they actually using 4 millimeter tunnel, which I think I will a little bit scared for that. Depending on the size of the patient, yeah. But I think the principle is try to minimize the tunnel size just good enough, and then has a gradual dilatation. You don't go straight into the 3 millimeters. You start with 2 and then gradually increase. That will keep you safe.
Thank you, Dr. Ho. There's a questions about so you do the total TFCC reconstruction. For example, Greg Bain and Billboard actually advocates that if the radial side, if the synovial side is intact, you can do a partial. You can just use a graft and tag along with the TFCC, and so it's like an augmentation. So what do you think about that, and have you had any experience on that?
Well, I use this tendon graft actually in the case with the ulnar styloid non-unit. I think there's also a question from the floor about the.
Yes.
I also show one case. In fact, my preference is to do repair of the non-unit with the tension band wire. But I understand many of the particularly non-unit, they're very hard to heal. And I tried bone graft and so on, they never heal. So basically, in those cases, I will augment with a tendon graft. It's just like breaking concept. But I think I used it very long time ago. So I just grabbed the tendon graft onto the outer side of the TFCC and pull them back to the ulnar. And then just like a figure of 8 and stretch on the outer side. I think it's what you say, the outer reconstruction. So I think if the ulnar side is still substantial, the TFCC is substantial, I think this is one advantage. But I have a little doubt because in terms of this stability, pulling onto the bone must be stronger than pulling onto the tendons or the TFCC structure. There are also sometimes, particularly for chronic case, there may actually risk of that tendon graft may actually tear through the fibrocartilage, particularly when this is a chronic case. The remnant of the fibrocartilage is actually very brittle. So it may not really easy to take the graft. So I think it depends on the situation. So I still find that it's very reliable and reproducible. It will do every time on the bone side, and it actually doesn't jeopardize any significant disadvantage because the radial tunnel is always very safe. Usually we very seldom have any problem. The outer tunnel is a small tricky.
Okay, thank you. Maybe how about Jeff and Sanjeev? What yes, Dr. Ho talked about the outer styloid management. So what do you guys think? If you, for example, I think you see a lot of cases, like especially distal radius fractures, they have outer styloid fracture that's going to non-union. The patients have some TFCC, have some DRUJ instability. And so would you do a fixation of the outer styloid after that, or would you just ignore the outer styloid, excise it, and then just do a repair reconstruction?
As a general rule, I ignore it because it rarely causes trouble. When you're doing your distal radius fixation, you're going to arthroscopy the radiocarpal joint with TFCC, and you deal with the TFCC. Rarely the ulnar styloid can cause pain because it has a non-union, and sometimes it can cause an attrition rupture or partial rupture of the ECU. I take it out. Everybody's got an ulnar styloid and it must be doing something. And we looked at our patients to see if there was a difference in the outcome in the patients that had their symptomatic non-unity ulnar styloid and their ulnar styloid excised. And we couldn't find a difference, which was somewhat disappointing.
So in the for an ulnar styloid non-union, so the chronic case, if it's a tiny little chip and they're symptomatic, then I'll just go in and I'll address the TFCC pathology. But sometimes it's rather sizable and the patient sees it, and even on the post-operative X-ray, if you haven't excised it and they have pain, they say, well, it's the styloid. You can see it right there. So then in those patients, then I'll excise it, and it's a sort of then a mini open incision, and then I'll repair it, probably more of an open procedure, a mini open procedure. But that's how I tend to deal with ulnar styloid non-unions.
Yeah. Thank you. Yeah.
Maybe we can ask one last question. So there's a question from the Q&A box about Galeazzi fracture dislocation. So they asked about if TFCC reconstruction is beneficial after a missed like the LUJ dislocation with not reducible the LUJ.
I think, it's a nice question. I think recently we have also some hot discussion about the Galeazzi fracture, whether we should fix the TFCC partner, or rather than the functional type of treatment, fix the radius and then pin the DRJ into supination. I think for hand surgeon, or particularly for wrist surgeon, comfortable with TFC repair, I strongly advocate that we should fix the TFC at the same time. Because anyway, the purpose of the fixing the radius is to allow early mobilization. You will fix the radius and then pin it, I think you will actually defeat all the purpose. Now you are confident and good repair. You should be able to confident to mobilize the patient. So I think I will strongly avoid. But if in case when you have a chronic miss DRJ instability after adequate fixation of the radius, or maybe the scenario is a chronic Galeazzi, even the radius has not been fixed. Of course, in that situation, of course, you have to do first principle, you have to fix the radius first, and most likely the DRJ will be unstable. And that's a situation where you may consider that a primary repair may not be strong enough to control. Then I will think that TFC reconstruction will has a good indicator in that situation. But it actually all depends, because after you're fixing the radius, which is, I think nobody will disagree with that, and then you interrupt, you test how easy to reduce. And secondly is how fresh is the TFCC still there. If it's not difficult to reduce, TFCC is still freshly seen, so repair is still an option. I will say that. But on the contrary, if everything is not favorable, then I won't hesitate to do that reconstruction.
Thank you.
Yep.
So I think the time is up.
Yes.
So we'll hand
so
back to our president.
Yeah. President-elect.
Thank you very much, Margaret and Esther. PCO and Jeff and Sanjeev, you've done a wonderful job, and thank you very much for a wonderful talk. Before I finish, I would like to advertise a few information which I would like to share with you. Can you find my slides?
Yes.
Yes, this master class is very important in terms of clinical and in our clinical practice. But actually, you can find more information, more educational contents if you follow all our social media in Insta, YouTube, and LinkedIn. So before I finish, I would like to remind you our APOA hand and upper limb meeting is going to be held this November again, because the APOA 2022, which was planned to happen in Manila, was converted into online, virtual. But still, our hand and upper limb society will have 2 full day of course. So please join us for APOA 2022, November 24th to 26th. And this is another important notice because our inaugural APOA hand upper limb meeting is going to happen in Seoul next year, June 30th to July 2nd. So this is going to be a face-to-face meeting. So please join us as soon as we advertise to you on web. So once again, thank you very much for your joining. And if you finish all the questionnaires, you will have the certificate of attendance. And I would like to deliver special thanks to all our speakers, special guests, and to our moderators. Thank you very much. Thank you.
Bye-bye.
Thank you. Bye-bye.
Bye-bye, everybody.
Esther,
Thank you very much.
Thank you
Margaret,
very
you've done
much.
a wonderful job. Thank you very much.
Good. Have a good weekend.
Yes,
Thank
Jeff.
you.
You too. Thank you very much. This was wonderful discussion.
Thank you so much, everyone.
Bye. Yeah, thank you. Thank you so much.
you.
Have a nice weekend.
Okay,
Thank you.
Dewi, live streaming finished?
Yeah, we finished.
Thank you.
We'll
Thank you.
stop it. Thank you.
Margaret, Esther,
Bye-bye.
thank you very much. I think